So welcome. Thank you so much for being here and joining us for Connections and Education Day for families of children living with Crohn's and colitis. It's so exciting to see so many of you. Can you hear me? Sorry, I can't hear myself. So many of you on a Sunday morning. My name is Jennifer O'Connor, and I am the Regional Director here at the Crohn's and Colitis Foundation. And we do a lot of programs every year, and I think this one is one of my favorite, and it's just really nice to have so many people out on a Sunday morning. We're really proud to present this program in partnership with Seattle Children's. Thanks to the amazing IBD team here for making this event possible, and special thanks to Teresa Walks, who is just coming in. Teresa is a big part of why this program happens every year, and we really appreciate it. As you may have noticed in your folders, the Foundation's tagline is Uniting to Care and Cure, and this program is a really great example of how we strive to partner with other members of our community to provide the best programs possible to help families and their loved ones. Before we begin, I wanted to share a little bit about the Crohn's and Colitis Foundation, especially for anybody who is new here today. I know we have some families that are joining us for the first time. The Crohn's and Colitis Foundation is a volunteer nonprofit organization, and our mission is to cure Crohn's and colitis and to increase the quality of life of those living with these diseases. Our mission really has two parts. So I keep thinking I have slides. The first is research. We are dedicated to funding research, and the second part of that mission is really providing patient education and support programs, which you'll hear a little bit more about throughout the day. We're also excited that this year we celebrated our 50th anniversary. And while we were very honored to celebrate such a historic milestone, I will say we do hope that we are not celebrating another milestone anniversary, because we truly do want to make these diseases history. So we were excited to celebrate, but hopefully that's the last one. In 2016, our research portfolio included over 200 projects being funded throughout the country. And last year, we invested over $30 million into IBD research. And we plan to see that number grow this year as well. Since the inception of the foundation 50 years ago, we've funded over $300 million in IBD research, and we truly sit at the center of the IBD research space. We're proud to be recognized as an organization that invests our donors' dollars wisely, and a lot of the funds that we raise come through various programs and events and individuals, some of them in this room. When you walked in, you probably noticed a table out there, and it shared some information on the different ways that you can get involved in the organization. We have our Take Steps Walk program, which Seattle Children's is a sponsor of and a part of. We have our Team Challenge Endurance program. We have our annual benefit luncheon. We do a flag football tournament at CenturyLink Field, and we have an event that's coming up this December called Spin for Crohn's and Colitis Cures. And I just encourage you to take a moment to stop by, check them out, and meet some of the amazing staff we have here today. None of them are actually in the room right now, otherwise I would introduce them. And lastly, before we kind of segue into today's program, I want to share a little information on a program of ours that I personally am really excited about. It's called IBD Partners, and IBD Partners is our patient-powered research network. It is a way for patients and actually families to get directly involved in the research that we're doing. There's some information out at our mission table. You can actually sign up to be a part of it. But what it is when you sign up to be partners, you're essentially filling out 2 surveys a year of patient-reported data. So there's surveys that are looking at different disease symptoms, fatigue, nutrition, a variety of other things, and that data is then being used and accessed from researchers all over the country. So it really is a way to get directly involved. We currently have 15,000 people enrolled in the program, and I encourage you to check it out. Everyone should have received a folder today. In that folder, there's copies of the slides on the presentations that you'll hear. You can take notes. There is information on all the events and the different programs we have. And there's also a bright orange flyer, and that is our assessment. We really encourage you to fill that out. It gives us a better idea of how we did today. It helps us provide better programming in the future, and we really do value your feedback. So in a moment, we'll have our kids and teens head down the hall, but before we do that, I wanted to welcome Teresa to share a little bit about today.
Good morning. Thank you for spending your Sunday with us. We'll keep you updated on the Seahawks score this afternoon, so we'll keep you tied in. So I'm really excited to see so many of you here and to see our kids here. Our goal is to have, us come together because we're partners. Whether you live, we've got some new friends from Oregon that are here, or if you're a Seattle native, there's a whole community. I mean, there's almost 2 million people in the United States that have Crohn's and colitis. So we're a small blip on that, but we're the ones that are going to support each other. So it's so helpful, we've seen, for families along the way to have an opportunity to meet each other and to hear different perspectives from different members of healthcare team. It does, just like it's going to take the whole team for the Seahawks to win this afternoon. It takes a whole team to make the journey for kids, which what we're dealing with today, have a successful journey in their dealings with Crohn's and colitis. So today we're going to give you information, some education. We're going to hopefully give you some new friends that you can connect with that will help you, parent to parent. And for the kids, you're going to meet some great kids today. You'll have fun. You'll learn some things. You'll talk about camp. For those of you that know me, it is my favorite thing, right? And again, we're just here. We're as a community. It takes a village to raise a child, and it takes all of us to get our kids with Crohn's to adulthood, and you'll meet some of our great kids that have grown up and that are going to work with your kids today that are pretty amazing. So again, welcome. Bathrooms just inside the front door where you came in, and also if you go out the door just to your left. We'll have lunch later this morning, and there's drinks and snacks out in the lobby there. If you have any questions or anything that you wonder about as the day goes on, I'm here, Kathleen's here, some of the speakers will be here, and we'll have our expert panel this afternoon, because we want you to leave here feeling like you knew a little bit more than when you came, and that you feel like you're just a little bit stronger to fight in this this battle that we're all dealing with. So thank you again for coming, and I'd like to introduce our first speaker. So one of my partners in crime in the IBD Center, Sarah Mbonde, is one of the RNs that works at Seattle Children's in the IBD Center. Oh, I forgot. So excited to introduce, people are doing jumping jacks and things in the back. So although everybody would like to meet Sarah, we'll have our kids go back with Kelty and Grace and go down to the more fun room. Oh, sorry, guys. Goodness, we have a lot of kids, don't we? I think we're going to have about 30 kids today. So at camp we have 145. So just think of how many fun kids we have coming. Okay, so now we'll have you meet Sarah Mbonde. She's one of the RNs in the IBD Center here at Children's. Some of you may have talked to her on the phone. She helps with developing education materials, taking care of patients, seeing you in clinic, and she's also one of our volunteers in the Health Hut at Seattle, or at Camp Oasis. So please welcome Sarah, who's going to try to give you some more information, IBD 101. Some of you may be able to give this lecture, but hopefully everybody will be able to glean out something new that you didn't know before you came in. Sarah, thank you.
Good morning, and thank you for spending your Sunday with us. We just wanted to include an overview of pediatric IBD because we know that some of you have been diagnosed for a very short amount of time. Others of you have, close to a decade of experience with this, but just so we have kind of a baseline. Hopefully I don't put too many of you to sleep this morning. I tried to find some new and exciting things. Okay, so our roadmap for this lecture, talk about what is IBD, the differences between Crohn's and ulcerative colitis, the prevalence of IBD in the US and around the world, possible causes of IBD that we've identified, the science of autoimmune diseases. They asked me to put a couple slides in on that. And then new findings in IBD, so new cool stuff that we've learned in the last year or so. So we'll start with what is IBD. So IBD is a general term describing 3 disease entities or 3 types of inflammatory bowel disease, commonly known as Crohn's disease, ulcerative colitis, or indeterminate colitis is what they'll call it if they're not sure if it's one or the other. Sometimes you can change diagnoses between ulcerative colitis to Crohn's disease, but usually don't go back the other way. So a little bit of the differences between them. Crohn's disease can occur in any part of the intestine. I really love this. Obviously, I found it from a European source, from gum to bum. And so you could have Crohn's disease in your mouth, in your throat, stomach, all the way down to the rectum and anus. Whereas ulcerative colitis is limited to the large intestine, so your colon and your rectum. This is one of the reasons why you'll sometimes hear that surgery can be curative for patients with ulcerative colitis, whereas we don't see that with Crohn's disease. Another difference is that Crohn's disease can skip areas, so you might have Crohn's disease in your mouth, your stomach, and say the end of your small intestine, but with ulcerative colitis, it typically starts from the rectum and it'll work its way up. So you might hear your provider talk about different kinds of ulcerative colitis or different kinds of Crohn's disease. The most common way to describe them is based on the location of the disease. And the location of the disease is important because that tells us which treatments are more likely to work for you or your child that's been diagnosed. It's also helpful in diagnosing it because ulcerative colitis, if we don't see involvement of the rectum in that first part of the intestine, it's more likely that we're looking at Crohn's disease if we're only seeing like the last part of the small intestine or last part of the colon there. So Crohn's disease, and I have pictures of this one too, you're welcome, the ulcers that can penetrate the wall of the intestine. So the entire lining can be impacted, whereas with ulcerative colitis, it's pretty much just the top layer that's impacted. And so this also is important when we're determining what kinds of medication and also how aggressive to be with the therapy and the treatment. You'll see on the left here, does my laser pointer works. Okay, so this is a normal healthy colon. This is our goal, to get everyone back to this point. And with appropriate therapy, it's very, very doable. So you can see in Crohn's disease, the second part here, there's involvement of the entire lining. You can get a fissure in here. If that goes all the way through, sometimes we can get things like abscesses. We really want to minimize the inflammation in here. Ongoing inflammation in Crohn's and ulcerative colitis can cause scarring and scar tissue, which is not treated by medications. And if it becomes too bad, it can lead to blockages, and we have to take it out with surgery. So controlling the inflammation is one of our biggest goals in this. In ulcerative colitis, we don't see that full thickness. It's just the layer that's impacted. But you'll get these little pseudopolyps, which are signs of inflammation in the large intestine. So again, just if you've received a diagnosis of Crohn's disease or ulcerative colitis, this is a little bit of a picture of what is going on inside and why treating it effectively is so important. Okay, so slide on IBD prevalence. This is a little bit of a timeline. These diseases have been around for a couple of centuries. They were first described in 1875. Fast forward to when we were able to collect data and communicate it a little bit more, we found the incidence of these diseases increasing at an exponential rate as, and we theorized that it's due to dietary changes, industrialization. As countries have become more westernized, we see the incidence of IBD increase. And my favorite slide. Okay, so you can see these are all different autoimmune diseases. So multiple sclerosis, Crohn's disease, type 1 diabetes, and asthma. You can see the exponential increases over the last 50 years. And again, we're not sure what's been causing this, but right now the incidence of IBD is close to 1 in every 200 individuals in the world. So very common diseases, and they're just becoming more and more common. So it's great that we're figuring it out and finding better and better ways to treat them. Okay, this didn't show up as much as I wanted it to. So hopefully this came out better in your handouts, but just another example of the increase that we've seen over a 10-year period from 1990 to 2001 as certain countries were becoming more industrialized. So Hong Kong, South Korea, and Brazil, we saw the incidence of IBD increase between 50 and 150%. So we know that there's something that's going on in the environment, in our communities, that is significantly contributing to this. And so we're working to identify that. So over 5 million people in the world have been diagnosed with IBD, 1.6 million in the US, and again, this number continues to rise every year. It's seen more in industrialized countries, and so we see most of it in the US, Canada, Europe, and then there's a large pocket in Australia as well. We see less of it in Africa and some of the other non-industrialized countries. It's also more common in the northern latitudes. So if you live close to the equator, you tend to be a little bit safer from IBD. It equally impacts males and females. And about 25%, some studies out of Europe say as high as 30% are diagnosed as children. So this is a huge impact to our kids, and it's very important to get this under control as quickly as possible so that they can go through puberty and adulthood and do all the great things that they want to do. There's been a lot of studies done with IBD. The Crohn's and Colitis Foundation and other organizations. Europe has a huge prevalence as well, and we find some interesting facts just in little pockets around the world. So we find things like there's a very low incidence in First Nation populations. So the Native American population in Canada has a very low incidence of IBD, whereas the South Asian population here in the Northwest, especially males, have a high incidence of pediatric IBD and a lot of colonic disease. So whether that's ulcerative colitis or Crohn's disease in the colon, we see a lot more of that here in the Northwest. In the US, we see the rising incidence, of course, from 1940 to 1993. And as I discussed in the last slide, this is a trend that we are seeing kind of across the world, especially in Europe and the US. And I won't go through all of these, but interesting ones. There's an increased risk of second-generation immigrants from Asia in the UK. So we're finding that when a population will transplant to Europe or the US, subsequent generations see similar increases in the IBD. Again, we've seen the rising incidence in Asia, paralyzing Westernization, so changing their diets. And we see it being very uncommon in places like Africa. It's also interesting, we see, where is it? This one here. Higher incidence of IBD in Israeli Jewish individuals as compared to the Arab counterparts. So just different pockets, different interesting things that we're finding about subpopulations. Okay, so what's causing this? We talked a little bit about Westernization and industrialization. But really, when it comes right down to it, we think that it's a combination of these 4 factors. And it's different for each individual, how much each of these factors plays into it. And so this can be important when we're determining what treatment is going to work best and why a treatment isn't working for you or your child. So IBD can be triggered by what we call a dysbiosis. And dysbiosis really means like an imbalance in the number of bacteria in your colon or in your intestines. So there are trillions of bacteria that live inside your gut. They do different things like making vitamins, helping you digest food. We're finding that some bacteria are better than others, and they live in a community. And so you can think, if you had a community where everyone was a car mechanic, it wouldn't work very well. So you need to have diversity in the microbiome in the gut. It's one of the reasons that we think the Western diet is so impactful with IBD and triggering it, is because when we see a lot of food preservatives, junk food, food additives, we tend to see a decrease in the different types of bacteria that are in the gut. And changing the diet can sometimes correct this. Other factors, there's a genetic piece to this puzzle. There's over 200 genes that we've identified that are contributing to your risk of developing IBD. So it's not causative. So if you have one of these genes, it doesn't mean you will have IBD, but it means that people with these genes are more likely to develop IBD, especially if they have one of the triggers, like the dysbiosis in their gut. Only between 5 and 20% of patients have a blood relative with IBD. In my practice, I tend to see this on the lower side. So not a lot of our patients will know someone who has IBD, which is why things like Camp Oasis and Crohn's and colitis events are so useful. Because you don't really go out there and share stories about your bowel habits. And this is one of the things that our kids find most difficult is finding people who can relate to them with what they're going through. The antibiotic exposure, so medications, has also been linked to developing IBD. This could go back to that balance of good bacteria and bad bacteria in the gut. But ironically, antibiotics are also at times used to treat IBD. So I'm not sure what's going on there. And the last factor is this mucosal immunology or the immune system disturbance. So whatever is the trigger, what tends to happen is our immune system gets triggered and we can't get it to turn off for whatever reason. And then you have development of IBD or an autoimmune disease. So they asked me to talk about the science of autoimmune diseases. Here it is in a nutshell. So this can be triggered by a very real infection, a very real threat. So you could get gastroenteritis, a stomach bug, something that your immune system should have reacted to. The problem is that it doesn't stop. And so it starts attacking healthy colon, healthy cells, and you have an overreactive immune system. This leads to inflammation and, in some cases, IBD. All right, so a little bit more of a scientific slide. So if you're not the scientific minded, feel free to glaze over. So this is one of the theories about the immune system becoming overreactive. So we have, this is the lining of your intestine. There's different cells in here called goblet and Paneth cells. And their job is to create a mucus layer. And this is protective against the bacteria in our digestive tract. Can also release peptides or particles that help to regulate the number and types of bacteria that are in our immune system. But when this gets triggered, what we see, and I'm not sure that it's showing up very well on the slides, this mucus layer gets thinner and thinner and actually disappears in some cases. And that triggers an inflammatory response. Bacteria are able to enter into the gaps that are caused by the inflammation, which triggers more immune cells, and we end up with damage to the intestines and IBD. Okay, let me go back to this one for a while. There was a slide that I wasn't able to get in here, but I want to talk about it a little bit. So our immune system has different pathways toward inflammation, and we're finding that it isn't always the same pathway of inflammation that's triggered for all individuals with IBD. So this explains why diet may work for some kids. Something called a mesalamine may work for other kids. Other ones will need an immunosuppressant or, specific parts of their immune system targeted. So as you go to more and more of these events, and in Dr. Suskin's talk, later when Dr. Lee talks, we'll get more in depth about the different kinds of treatment. But you'll hear things like anti-TNF or IL-23 or SMOD7, and these are all different parts of the inflammatory pathways that are in our bodies, and we have medications that can block that or decrease that response. In turn, that leads to a decrease in inflammation, and it puts us into remission. All right, so when the inflammation is active, what are our IBD symptoms that we see? And I'm sure that many of you have seen a lot of these, as most kids get diagnosed in the middle of a flare. Now, these symptoms come and go. They're very individual. And so the IBD for your child may look very different from the person sitting behind you or the one sitting to your right or left. So these aren't things that will happen for everybody, but they're things to look out for because it could mean that the IBD is becoming active again. So keep an eye out for things like abdominal pain, diarrhea, weight loss, rectal bleeding or bleeding in the stool, growth impairment. We see some perirectal disease, things like skin tags, lumps or bumps, drainage down there. Anxiety and depression are really common in kids and individuals with IBD, so have that on your radar as well. And then we also have this fun group called extraintestinal manifestations. So things that you would not associate with the GI tract and IBD, but it could be related. So things like joint pain, rashes. There are certain rashes that are associated with different medications or just associated with inflammation in general. Iritis or sensitivity to light. So that's an inflammation in your eyes. And bone loss or demineralization. So One thing that I tell my patients when we're doing the education is remember how you feel when you were first diagnosed, because that's most likely to be the symptoms that you'll have when you have a flare again. So if you see those things again, be sure to communicate with your IBD team so that we can catch it early. So IBD treatment goals, these are a little bit more specific for our pediatric population because this is pediatric IBD talk. No symptoms. So we don't want them to have joint pain. We don't want them to have abdominal pain. We don't want them to have diarrhea. If you're still seeing these and you're on a maintenance treatment, have those conversations with your team because we may be able to make it even better. This disease should be able to be very little impact. For our kids, we want them to have normal growth and advancement through puberty. When we see active IBD, we can see things like delayed start of puberty. Sometimes girls, when they're in a flare, their periods will stop. We also want to see normal labs, so those normal inflammatory markers, normal hematocrit and hemoglobin, so that you have enough red blood cells. Normal bone health. Active inflammation can also decrease bone mineralization, and so if you have active inflammation or if you're using a lot of steroids in particular, it can lead to weaker bones. So we also want to see, of course, the healing of the intestines. And so sometimes you'll have a provider that says, let's do a colonoscopy even though you feel well. We do this a lot in the adult populations, having regular colonoscopies just to make sure that you're still in the mucosal healing. And the reason why that's important is because when we see the intestinal mucosa healed, we see fewer complications from IBD. So we see fewer of the abscesses and fissures and scarring and things like that. All right, wow, really went through these slides. I wanted to leave lots of time for questions. So one of my favorite slides though, what's new in IBD? So did you know that this year we got a new drug approved for Crohn's disease? If you've heard the commercials for Stelara, Stelara is, I believe, an IL-23 inhibitor. So different than Remicade and Humira, which a lot of you have probably heard about. Those are our anti-TNF blockers. So one of those inflammatory pathways that I was talking about. This medication, Stelara, blocks a completely different inflammatory pathway. And so we're very excited about this one because we're hoping that kids that we haven't been able to get into remission with our other drugs may respond to this better. Another very exciting thing that we've seen hitting the US markets this year is biosimilar medications. Have you guys heard about these? So biosimilars are like our biologic medications, so Humira and Remicade, but they're much easier to manufacture. They work just as well, and some of the studies that we've seen have told us that you can switch from Remicade or Humira to one of these biosimilar medications, which cost a lot less, work just as well, and you don't lose response. So you stay in remission. And I think Dr. Suskin might talk about that a little bit more in the next talk. We have new different medications in the pipeline. So the pipeline is the term that we use for what's being researched out there. Some of these things are being researched right here in our own backyard. So at the University of Washington and at Virginia Mason, we're looking at things like SMAD7, something called a JAK inhibitor, an S1P. So again, these are different inflammatory pathways. And we think that these are going to have less of an impact on our immune system overall. And so what this can mean for our patients is fewer of the side effects that we see with some of the anti-TNFs. So not impacting your immune system as much. So not seeing the increased number of infections that you can see with some of the other medications potentially. Not having as much of that impact on our bodies. We're finding out more and more about diet in IBD. There's a lot of well, I see a lot of adult doctors, but probably pediatric too, that will say diet doesn't matter. You just need to get on a medication. I work here at Seattle Children's with Dr. Suskin, and he does a lot of the dietary research in IBD, and we're finding, to the contrary, diet is very important. And we're finding, kids that eat a healthier diet decrease the food additives, the junk food in their diet. Even changes like that help our medications work better, and they help these kids have fewer symptoms and less of an impact on IBD. So even if they're not using dietary therapy as their only treatment, it is important to eat a healthy diet. And we have ongoing research about that gut microbiome, so that dysbiosis. We're figuring out what bacteria and how many of the different types of bacteria make a healthy microbiome. Preliminary findings are that the more diverse it is, the better. Some of our studies here at Children's showed that all of the patients started out with that dysbiosis or not very many bacteria in their GI tract, sometimes what we labeled as bad bacteria. And when we did significant dietary changes, that shifted, and the kids had fewer symptoms and went into remission. So that's what I know of as new in IBD. I left a couple minutes, actually quite a few minutes, for questions, and I intentionally left this vague. So what do you want to know about IBD?
Can you speak to the Stelara and the, sorry.
Yes.
Thank you. The Stelara and the biosimilars, are they injectable or infusion? What's the method?
Yeah, of course. So Stelara starts as an infusion. The very first dose is given IV infusion, and then it goes to injections. The SMAD7, JAK inhibitors, and S1Ps are a combination of injections, but we also have a couple oral, like pills, in that category. So that's
specifically what I was curious
exciting as
about,
well.
if we could ever go from injection or infusion to a pill.
Yeah, I think I'll say Mongersen is one that's being studied right now, and that's an oral medication.
Great, thank you.
So
Thank
very
you.
exciting.
Thanks.
Other questions?
Even though we've been in the IBD community for a few years, I didn't know about the different pathways to inflammation. This is the first time I've heard about it. Could you share a little bit more about that?
Yeah, and it's coming from some of the new research that we're doing. We're finding that different inflammatory pathways are impacting individuals differently. So it's not just the same inflammatory pathway, and we're finding that we can intervene at different parts of the pathway, and so that's what some of the medications here are, just intervening earlier or later. I heard a great analogy, to stick with the Seahawks and the football theme. So if you can block it earlier, then you have a greater impact. I don't know if that makes sense. Other questions?
Hi. I was wondering how did they make a decision when to switch to these new medications? Like if something's already working, is there something that makes them override what you're currently using?
Yeah, so generally, if someone is tolerating their medication well, we don't advocate for switching. In the medical world, we call that non-medical switching, because there's no guarantee that that other therapy is going to work. We may see something with the biosimilars. We haven't seen it yet, but in other countries that have socialized medicine, we have seen a mandated switch from Remicade to Inflectra, which is the biosimilar, and that's how we know that that switch in particular doesn't seem to be impactful. But in general, the time that you switch therapies is when the other therapy stops working.
So I had just a question about your fit between Crohn's and ulcerative colitis. It means that in that diagram you have more fat around the intestine than Crohn's. Is that significant?
Yeah, I'm not sure of the significance of it, but it's a very interesting finding. So sometimes when people are doing surgery, they'll see the fat, they call it fat stranding around the intestines, and then that can trigger someone to get worked up for Crohn's disease. Oh, sorry.
Oh, sure. So I just had just a question regarding Crohn's versus ulcerative colitis and whether the increased fat around the Crohn's disease was significant in terms of causation or anything else.
No, I think it's just a sign or something that says that this is more likely to be Crohn's disease than ulcerative colitis. A lot of times we don't even see that because when we do colonoscopies, we look at the inside of the intestine. So that's usually only a finding that's seen, I've heard it a couple times when patients go in for like an appendectomy and the surgeon will see fat stranding and have them worked up for IBD. Other questions? Are you guys asleep or did I really do that well? All right, thank you.